Hello, my name is Naomi, and today I will be guiding you through how a fertilised cell develops into a baby and how your baby's growth and well-being are monitored throughout the pregnancy and labour using tools such as ultrasound and other measurements. I'll also be covering screening for genetic conditions like Down syndrome and sickle cell anemia. Finally, we'll look at the risk factors of miscarriage, clear up some common misconceptions, and explain when termination may be considered, providing clear, supportive, and evidence-based information throughout. In this section, I will explain how a healthy embryo and fetus develops in the uterus from conception through to birth. Development begins at fertilisation, when a sperm cell joins with an egg to form a single cell known as a zygote. This cell rapidly divides through a process called mitosis, forming a cluster of cells. By around day 5, this becomes a blastocyst, which implants into the lining of the uterus. This is a crucial stage as successful implantation allows pregnancy to continue. During this time, important supporting structures begin to form, including the placenta and extraembryonic membranes, which will provide nutrients, oxygen, and protection for the developing fetus. The embryonic stage occurs between 4 and 8 weeks. This is one of the most critical periods of development. During this time, the foundations of all major organs and body systems are formed. The heart begins to beat at around 5 weeks, and early structures such as the brain and spinal cord develop from the neural tube. Limb buds begin to appear, which will later form arms and legs. At this stage, the embryo is very small and vulnerable, and exposure to harmful substances can significantly affect development. From around 9 weeks onwards, the developing baby is referred to as a fetus. At this point, all major organs have formed, but they are not yet fully functional. The focus now shifts to growth and maturation. The fetus begins to develop more recognisable human features, including eyes, ears, and nose. Limb buds become longer and more defined, and this marks the beginning of a period of rapid growth and increasing complexity. During the first trimester, major body systems begin to function. The heart is beating regularly, and the brain is developing rapidly. Although the fetus begins to move, these movements are usually too small to be felt by the mother at this stage. The placenta is now established and plays a vital role in supplying oxygen and nutrients, as well as removing waste products. In the second trimester, the fetus grows significantly in size and strength. One key development is ossification, where soft cartilage begins to turn into bone, strengthening the skeleton. Movements become stronger and are usually felt by the mother, often described as quickening. Sensory development also begins at this stage. The fetus starts to respond to touch and may begin to detect sounds from outside of the womb. Research shows that sensory and motor development begins before birth. The fetus can respond to touch and sound, and movements become coordinated over time. Hearing develops in the second trimester, and the fetus may respond to voices, particularly the mother's voice. Studies suggest that early learning may begin in the womb as the fetus becomes familiar with sounds and patterns from the external environment. In the third trimester, the fetus prepares for life outside of the womb. There is rapid weight gain, and fat is stored to help regulate body temperature after birth. The lungs mature, which is essential for breathing independently, and the brain undergoes significant development. At this stage, the fetus becomes more responsive to stimuli such as light and sound, and has more regular sleep and wake cycles. Unlike after birth, the fetus does not use its lungs to breathe. Instead, oxygen and nutrients are delivered through the placenta via the umbilical cord. Fetal circulation is specifically adapted to bypass the lungs, ensuring oxygenated blood is delivered efficiently to vital organs such as the brain. By the end of pregnancy, the fetus is fully developed and preparing for birth. Most babies naturally move into the head down position, known as the cephalic position, usually between 32 and 36 weeks of pregnancy. This position is important because it allows the baby's head, which is the largest part of the body, to pass through the birth canal first, making labour safer for both mother and baby. The movement into this position is influenced by several factors, including the shape of the uterus, gravity, and the baby's increasing size, which limits space for movement. As a result, movements may feel different to the mother, often stronger but less frequent. At this stage, the baby has also developed reflexes such as sucking and grasping, which are essential for feeding and interaction after birth. The brain and nervous system are well developed, and the baby can respond to stimuli such as light and sound. Overall, the fetus is now fully prepared to transition from the womb to the outside world. In this section, I will explore and explain the different ways imaging is used to monitor the health and development of the fetus during pregnancy. This includes ultrasound scanning, Doppler technology, and the measurement of fundal height. Monitoring during pregnancy is essential to ensure that both the mother and baby remain healthy. It allows healthcare professionals to track the baby's growth, detect any potential complications early, and make informed decisions about care. Regular monitoring can also provide reassurance to parents and help guide further tests or interventions if needed. Ultrasound is one of the most used imaging techniques in pregnancy. It works by using high-frequency sound waves to create real-time images of the baby inside of the uterus. Unlike X-rays, ultrasound does not use radiation, making it safe for both the mother and the developing baby. It is a non-invasive procedure and plays a key role in routine antenatal care. Ultrasound scans provide a wide range of information about the baby's health. They can show the baby's size and growth, detect the heartbeat, and identify the baby's position within the uterus. They can also confirm how many babies are present and assess the position of the placenta, which is important for planning a safe delivery. There are two main types of ultrasounds used during pregnancy. An external ultrasound involves moving a probe across the abdomen to produce images of the baby. This is the most common type used throughout pregnancy. An internal or transvaginal ultrasound involves inserting a probe into the vagina. This may be used in early pregnancy or when more detailed images are needed, as it can provide clearer views of structures such as the uterus and cervix. In the UK, pregnant individuals are usually offered at least 2 routine ultrasound scans. The first, between 11 and 14 weeks, is also known as the dating scan. It confirms the gestational age and estimated due date. The second, between 18 and 21 weeks, is the anomaly scan, which checks the baby's development in more detail and looks for structural abnormalities. A Doppler ultrasound is a specialised type of ultrasound that measures blood flow within the body. In pregnancy, it is used to assess how well blood is flowing through the placenta and umbilical cord. This is important because it helps determine whether the baby is receiving enough oxygen and nutrients to support healthy development. There are different types of Doppler scans used depending on the clinical situation. A uterine artery Doppler assesses blood flow to the uterus and placenta. If resistance to blood flow is high, this may indicate an increased risk of complications such as poor fetal growth. An umbilical artery Doppler measures blood flow through the umbilical cord. This is particularly useful in identifying conditions such as growth restriction or placental problems. Doppler scans are not always used routinely, but are often recommended in higher risk pregnancies. For example, they may be used if the baby is not growing as expected, if the mother has conditions such as preeclampsia, or if there have been a history of complications in previous pregnancies. The fundal height measurement is a simple, non-invasive method used during routine antenatal appointments. It involves measuring the distance from the pubic bone to the top of the uterus, known as the fundus. This measurement provides an indication of how the baby is growing. From around 20 weeks of pregnancy, the fundal height in centimetres typically corresponds to the number of weeks of gestation. For example, at 28 weeks, the measurement is usually around 28 centimetres. This method is useful for identifying whether the baby is growing as expected. However, if it is only an estimate and it can be affected by factors such as maternal body size or the baby's position. If measurements are outside of the expected range, further investigations such as ultrasound scans may be recommended. Overall, there are several important methods used to monitor the health and development of the fetus during pregnancy. Ultrasound scans provide detailed imaging, allowing healthcare professionals to observe the baby's growth, position and development. Doppler ultrasounds adds further information by measuring blood flow through the placenta and umbilical cord, helping to identify whether the baby is receiving oxygen and nutrients. Fundal height measurement is a simple and non-invasive method used during routine antenatal care to track the growth of babies over time. These methods are used together quite often to build a clear picture of the baby's well-being and to support safe and effective pregnancy care. Here I will explore fetal monitoring during the different stages of labour, identify when additional monitoring may be required, and explain how monitoring can lead to interventions or changes to birthing plans. Labour occurs in 3 stages. The first stage involves cervical dilation, and second stage is the birth of the baby. And the third stage is the delivery of the placenta. Monitoring is carried out throughout all stages to ensure both the baby and mother remain safe. During labour, both the mother and baby are closely monitored. For the baby, the most important factor is the heart rate, as this indicates how well the baby is coping with labour. For the mother, observations such as heart rate, blood pressure, temperature, contractions, and cervical dilation are monitored to assess progress and well-being. In low-risk pregnancies, intermittent monitoring is commonly used. This involves listening to the baby's heart rate at regular intervals, typically every 15 minutes in the first stage of labour and after contractions in the second stage. This method allows greater mobility and can use tools such as a Doppler device or a pinard stethoscope. In higher risk situations, continuous monitoring using cardiotography or CTG may be used. This records the baby's heart rate continuously alongside contractions, producing a trace that can be analysed to assess the baby's well-being. There are several types of continuous monitoring. External monitors are placed on the abdomen. Telemetry allows wireless monitoring, enabling some movement. In more complex cases, a fetal scalp electrode may be attached to the baby's head for more accurate readings. An intrauterine pressure catheter may also be used to measure the strength of contractions if more detailed monitoring is needed. Monitoring varies across the stages of labour. In the first stage, checks are carried out regularly to ensure the baby is coping with contractions, and in the second stage, monitoring becomes more frequent as the baby experiences increased physical stress while moving through the birth canal. Monitoring changes depending on the stage of labour and how the baby is responding. In the first stage, the baby's heart rate is usually checked regularly, typically every 15 minutes to ensure baby is coping. In the second stage, when the baby is being delivered, monitoring becomes more frequent and is often carried out after each contraction, as this is when the baby is under the most physical stress. Healthcare professionals are not only checking the heart rate itself, but also looking for patterns and changes over time, as these can indicate how well the baby is receiving oxygen and whether any further action may be needed. The baby's position in labour is also important. The ideal position is head down, known as the cephalic position. If the baby is breech or in another abnormal position, additional monitoring and interventions may be required to support a safe delivery. If monitoring identifies concerns, this can lead to interventions. Initial responses may include changing the mother's position or stimulating the baby's scalp to improve heart rate. If concerns continue, assisted delivery using forceps or ventouse may be required, or in more serious cases, an emergency C-section may be performed. A birth plan outlines a mother's preferences for labour, but these plans may need to change based on monitoring results. For example, if continuous monitoring is required, a water birth may no longer be possible. Similarly, complications such as a premature labour or fetal distress may lead to different delivery methods being recommended. In all cases, the priority is ensuring the safety of both mother and baby. In this section, I will describe the screening processes used during pregnancy to identify chromosomal abnormalities such as Down syndrome, Edwards syndrome, and Foetal syndrome. I'll also describe how genetic screening is carried out for hereditary conditions, using sickle cell anemia as an example. Screening tests are offered during pregnancy to identify the likelihood that a baby may have a certain genetic or health condition. It is important to understand that screening does not provide a diagnosis, it only indicates the level of risk. Parents can decide whether to have further diagnostic tests, and all screening is optional, and individuals are supported in making informed choices. Chromosomal abnormalities such as trisomies occur when there is an extra copy of a chromosome. The three main conditions screened for during pregnancy are Down syndrome, Edwards syndrome, and Foetal syndrome. Each condition affects development in different ways depending on which chromosome is involved. Down syndrome, also known as trisomy 21, occurs when there is an extra copy of chromosome 21. It is associated with learning difficulties and may involve additional health conditions such as heart defects, as well as hearing or vision problems. The effects can vary between individuals. Edwards syndrome, or trisomy 18, is caused by an extra copy of chromosome 18. This condition can affect several body systems, including the heart, lungs, and digestive system. It is often life-limiting, and many babies do not survive beyond infancy. Foetal syndrome, or trisomy 13, is caused by an extra chromosome 13. It can result in severe physical abnormalities such as a cleft palate and organ defects. It is associated with a high risk of miscarriage and is considered life-limiting in most cases. The combined screening test is offered between 10 and 14 weeks of pregnancy. It includes an ultrasound scan to measure nuchal translucency, which is the fluid at the back of the baby's neck, along with a blood test. These results are combined to estimate the likelihood of chromosomal conditions. If the combined screening test shows a higher likelihood of a condition, further tests may be offered. One option is non-invasive prenatal testing, or NIPT, which is a blood test that analyses small fragments of the baby's DNA circulating in the mother's blood. This provides a more accurate estimate of risk. If a more definitive answer is needed, diagnostic tests may be offered. These include chronic villus sampling, where a small sample of placenta is taken, and amniocentesis, where a sample of amniotic fluid is collected. These tests can confirm whether a condition is present, but they do carry a small risk of miscarriage, so they are optional and carefully discussed with parents. Sickle cell anemia is a hereditary blood disorder affecting haemoglobin. In the UK, screening is offered to all pregnant women, ideally before 10 weeks of pregnancy. This is carried out using a blood test to identify whether the mother is a carrier. If she is identified as a carrier, the other baby's parent is then offered testing. This process helps identify the likelihood of the baby inheriting the condition. If both parents are carriers of the sickle cell gene, there is a 1 in 4 chance the baby will have the condition and a 2 in 1 chance the baby will be a carrier. At this stage, diagnostic tests such as CVCs or amniocentesis may be offered to determine whether the baby is affected. These tests are optional and require careful consideration due to a small risk of miscarriage. Fetal anemia occurs when the baby has a reduced number of red blood cells, which can affect oxygen delivery. It is often caused by blood group incompatibility between the mother and baby. Screening is commonly carried out using Doppler ultrasound, which can detect increased blood flow velocity. Faster blood flow can indicate that anemia may be present. Further tests may be used to confirm the diagnosis. If fetal anemia is confirmed, treatment may be required depending on severity. One option is an intrauterine transfusion, where compatible blood is delivered directly to the baby through the umbilical cord. This is carefully monitored using ultrasound. In some cases, early delivery may be considered so the baby can receive treatment after birth. In summary, screening during pregnancy helps identify the risk of chromosomal, genetic, and other health conditions early on. This supports informed decision making and improves outcomes for both mother and baby. In this section, I will explain some of the risk factors of miscarriage, addressing common misconceptions about what causes miscarriage, describe ways to reduce risk, if possible, and outline the medical or surgical interventions that may sometimes be needed. A miscarriage is the loss of pregnancy before 24 weeks. Most miscarriages happen during the first trimester, especially in the early weeks of pregnancy. It is important to explain that a miscarriage is common and in many cases cannot be prevented. It can also be a very distressing experience, physically and emotionally, so care must be delivered sensitively and without blame. One of the most common causes of miscarriage is chromosomal abnormality, where the embryo does not develop normally. This usually happens by chance and is not caused by anything the parents did. Other factors that can increase the risk include increasing maternal age, smoking, drug misuse, and alcohol use. Certain health conditions, such as poorly controlled diabetes or some hormonal and immune conditions, may also increase risk. Having previous miscarriages can sometimes increase the chance of another miscarriage, although many people go on to have healthy pregnancies afterwards. Other possible risk factors include infection, obesity, some structural problems of the uterus, and cervical weakness. Pregnancy complications such as ectopic pregnancy are also important to identify. This cannot continue safely and can become a serious medical emergency. There are also many misconceptions around miscarriage, and it is important to dispel these. Miscarriage is not usually caused by everyday stress alone, by normal exercise, by sex during a healthy pregnancy, or by lifting something light once. Many people blame themselves after a miscarriage, but in most cases it is not caused by anything they did or did not do. Explaining this clearly is important because reducing guilt and self-blame is an important part of compassionate care. Although not all miscarriages can be prevented, risk may be reduced in some cases. This includes avoiding smoking, alcohol, and non-prescribed drugs, attending antenatal appointments, and managing existing health conditions such as diabetes. It is also important to seek medical advice promptly if there is bleeding, pain, or other concerning symptoms in early pregnancy so that assessment and support can be offered. Bleeding in early pregnancy does not always mean miscarriage, but it should always be assessed. Symptoms that may need urgent review include vaginal bleeding, abdominal pain, cramping, passing tissue, and in some cases, shoulder tip pain, dizziness, or collapse, which may suggest an ectopic pregnancy. Prompt assessment is important so that the cause can be identified and appropriate care can be given. When miscarriage is suspected, healthcare professionals will usually take a history of symptoms, carry out an examination if needed, and arrange investigations such as an ultrasound scan and blood tests. Ultrasound is used to check the location and development of the pregnancy, while blood tests may be used to measure hormone levels or check for complications. Sometimes more than one assessment is needed over time before a clear diagnosis can be made. In some cases, medical management may be offered to support the miscarriage process. This involves using medication to help the uterus contract and pass pregnancy tissue naturally. It can be an alternative to surgical management and may be preferred by some individuals. The process can involve bleeding and cramping similar to a heavy period. Follow-up care is important to ensure the miscarriage is complete and to check for any sign of complications such as infection or ongoing bleeding. Surgical management may be recommended in certain situations, such as if there is heavy bleeding, signs of infection, or if the miscarriage has not completed naturally. This procedure involves removing any remaining pregnancy tissue from the uterus and is usually carried out in a hospital or clinic setting. It may be performed under local or general anaesthetic, depending on the circumstances and patient preference. The procedure itself is relatively quick and recovery is usually straightforward, with follow-up care provided to ensure there are no complications. An ectopic pregnancy is a separate but important complication to explain. This occurs when the pregnancy develops outside of the uterus, usually in the fallopian tube. Because the pregnancy cannot grow safely there, treatment is necessary. Management may include medication or surgery, depending on the stage and severity. Without treatment, ectopic pregnancy can cause internal bleeding and become life-threatening. As well as physical care, emotional support is essential. Miscarriage can be traumatic and many people respond in very different ways. Some may feel grief, guilt, numbness, or anger, while others may struggle more later on. Clear explanations, sensitive communication, and access to support are all important parts of midwifery care. In summary, miscarriage is often due to chromosomal abnormalities and is rarely caused by anything the pregnant person has done. While some risk factors can be reduced, many miscarriages cannot be prevented. It's important to challenge misconceptions and ensure care is safe, clear, and compassionate when treatment is needed. Finally, I will explain some situations where a termination of pregnancy may be considered and describe the processes involved in both medical and surgical termination. This will include when termination may be recommended for medical reasons, as well as how care is provided and supported throughout. Termination of pregnancy, also known as abortion, is the process of ending a pregnancy. In the UK, it is a legal medical procedure carried out under regulated conditions with support from trained healthcare professionals. There are two main methods: medical termination, which uses medication, and surgical termination, which involves a procedure. Termination may be considered in a range of situations. This may include risk to the mother's physical or mental health, or where continuing the pregnancy could cause harm. It may also be considered if the fetus has a serious condition or abnormality that is incompatible with life, or if the pregnancy is not viable. In some cases, personal, social, or emotional circumstances may also influence the decision. All decisions are supported by healthcare professionals to ensure informed and safe care. In some cases, termination is considered for medical reasons. This may include severe chromosomal conditions, such as those discussed earlier, where the baby may not survive or may experience significant suffering. It may also be recommended if continuing the pregnancy poses serious risk to the mother's health. These decisions are often complex and are made with support from healthcare professionals, ensuring that parents are fully informed and supported throughout. Medical termination involves using medication to end a pregnancy and is most used in early pregnancy. It usually involves a two-stage process, and depending on the stage of pregnancy and clinical guidance, may take place at home with medical support. The process of medical termination involves two medications. The first medication stops the pregnancy from continuing by blocking hormones. The second causes the uterus to contract and expel the pregnancy tissue, similar to a miscarriage, and this process can involve bleeding and cramping, and follow-up care is important to ensure the procedure is complete and to check for any complications. Surgical termination is a procedure carried out in a clinical setting. It is usually quick and may be recommended depending on the stage of pregnancy, medical circumstances, or patient preference. It is performed by trained healthcare professionals in a safe, controlled environment. During a surgical termination, the cervix is gently opened or dilated and the pregnancy tissue is removed using gentle suction. The procedure is usually carried out under local or general anaesthetic and takes around 5 to 10 minutes. Afterwards, the patient is monitored for a short period before going home, and follow-up care is provided if needed. Termination of pregnancy is a safe procedure, and when carried out by trained professionals, patients are provided with aftercare, including advice on recovery, future contraception, and when to seek medical advice and help. Emotional support is also available, as experiences and feelings can vary greatly between individuals. It is important to recognise that termination is a personal and sometimes difficult decision. Healthcare professionals, including midwives, will provide clear, unbiased information as well as support to all individuals without judgment. Respect, compassion, and understanding are key to ensuring safe and appropriate care. Clear information and compassionate, non-judgmental care are essential when making these decisions. To summarise, this presentation has covered pregnancy from early stages of development to birth, including monitoring, screening, miscarriage risks and termination. Overall, it highlights the importance of informed decisions and supportive care. Thank you for listening.